Hello friends, today we will be discussing about the bronchiectasis in this video. As I have already discussed about the chronic obstructive pulmonary disease, this is also one of the entity in the chronic obstructive pulmonary disease. And what is chronic obstructive pulmonary disease? As the name itself, it suggests that there can be obstruction in the respiratory tract, and that obstruction can be either partial or it can be complete obstruction. And the obstruction can be present anywhere in the airway, starting from the trachea to the smallest airways. And when there is an obstruction, that obstruction, it leads to the functional disability of the lungs. So this condition, we call it as chronic obstructive pulmonary disease. And in this, we have a few entities like chronic bronchitis, emphysema, bronchial asthma, bronchiectasis, and bronchiolitis. And today we'll be discussing about the bronchiectasis in this. Now, what is the definition of the bronchiectasis? Bronchiectasis means we have abnormal and irreversible dilatation of the bronchi, which occurs because of the inflammatory destruction of the wall of the bronchi. That is, the wall contains elastic tissue and the muscular tissue. So we have the destruction of the elastic and the muscular tissue of the bronchial wall, because of which the bronchi will be dilated. So bronchiectasis is nothing but it is abnormal and irreversible dilatation of the bronchi due to the weakening of the bronchial walls, which is mainly because of the inflammatory mediators. So here you see this is a normal structure of the bronchi, where we have a ciliated pseudostratified epithelium and then we have a muscle layer. Now in the bronchiectasis, we have the inflammatory cells in the wall, and then we have the ulceration of the mucosa, and then we have the destruction of even the muscular tissue. So because of the destruction of the muscular tissue and elastic tissue, we have the dilatation of the bronchi. Now broadly, the causes or the etiological factors of the bronchiectasis are classified as obstructive causes and the infections, and then we have the congenital or the hereditary conditions. So when we see in the obstruction, this is one of the commonest cause in the elderly age group. And here the obstruction can be either because of the foreign body, or it can be because of the tumor, or there can be a viscid mucous plugs which cause the obstruction, or there can be the lymphadenopathy adjacent to the airways, which will be causing the compression and the obstruction. So these are all the causes in the obstructive etiology. Then when we see the infection, this is the most common cause when the patient has a childhood respiratory infections, mainly because of the bacteria, or it can be because of pertussis, measles, adenovirus, or respiratory syncytial virus. Now in these conditions, the patient will have the childhood infection and later he develops the bronchiectasis. And there is another category of the conditions, that is congenital conditions or hereditary conditions. In this we have congenital bronchiectasis, cystic fibrosis, immotile cilia syndrome, or this is also called as Carter-Gunner syndrome. Then we have hereditary immune deficiency diseases and atopic bronchial asthma. So these are all the causes for the bronchiectasis. Now when we see the mechanism, pathogenesis, we have the two main mechanisms for the bronchiectasis, that is obstruction and infection. Actually, the both of them are interrelated. When there is an obstruction to the airway, there will be accumulation of the mucinous secretions distal to the obstruction. So this accumulated secretions, they have the proteinaceous material, and it becomes a good source for the growth of the bacteria. So you have a secondary bacterial infection. Then because of the infection, there will be an inflammatory reaction. So all the inflammatory cells coming there, they will release the mediators which will cause the destruction of the bronchial wall. So this can lead to the bronchiectasis. Another thing is, when there is a destruction because of the mediators, even the epithelium is lost, which is ciliated. If the epithelium doesn't have the cilia, the secreted mucin cannot be pulled up. So what happens is, when there is an impaired mucociliary mechanism, all the secretions which are produced, again they start accumulating, and again it will be infected. So this becomes a vicious cycle. This is the main mechanism for the bronchiectasis. Now this already I have told you how the obstruction causes. This is a normal bronchi. If you see, if here we have an obstruction, Then we have accumulation of the secretions distal to the obstructions. So in these secretions, which is mucinous material with a proteinaceous substance, bacteria grows in these secretions. Once the bacteria grows, then we have an inflammatory reaction, and the inflammatory cells, all the inflammatory cells are infiltrating into the wall of the bronchi. Then once they infiltrate the neutrophils, they will be releasing the proteases, and we have the cytokines and the reactive oxygen species which are released by this inflammatory cells. So these proteases and all the cytokines, they cause damage to the wall. So we have ulceration of the epithelium, we have destruction of the elastic and the muscle tissue. So we have an abnormal dilatation of the bronchi, and along with that there will be a thick mucin in the lumen. So this abnormal dilatation of the bronchi, that causes the bronchiectasis. This is how the obstruction causes bronchiectasis. Now next is how the infection causes. Already I told you, infection which occurs in the childhood, that becomes a common cause for the bronchiectasis. So in the childhood, when there is an infection and the inflammatory reaction, there is a destruction of the wall, and there will be the fibrosis. So once there is a fibrosis, the contraction of this fibrous tissue, it produces the scarring. So if you see here, there is a scarring and the contraction which causes obstruction. So that causes the obstruction of the bronchi, and again the remaining thing becomes the same. When there is an obstruction, there is an accumulation with secondary bacterial infection. Then you have an inflammatory process, then you have destruction of the wall and the abnormal dilatation, and that causes the bronchiectasis. And this way, infection which is usually acquired in the childhood becomes one of the cause for the bronchiectasis. Now in the hereditary conditions, I told you the cystic fibrosis we have, and Carter syndrome, immotile cilia syndrome we have. So we'll see this. Cystic fibrosis is a condition where we have mutation of this CFTR gene. Now normally when we see the lining epithelium, we have a ciliated pseudostratified columnar epithelium. So this ciliated epithelium, on the surface of this epithelium we have a liquid which contains more salt and the water, and on the surface of this salty solution we have a thick mucinous layer. So thick mucinous layer is immediately not present on the epithelium. Instead, in between this mucinous layer and the epithelium we have a salty water which is less viscous, so that the cilia can move. Now why we have this less mucinous or less viscous area is, these epithelial cells have on their surface the ionic transporter proteins. So because of this, the sodium will be moving into the cell, whereas chloride will move out from the intracellular compartment to extracellular compartment. And this transporter of the chloride is mainly the CFTR protein, which is produced by the CFTR gene. So as the chloride is moving out, even the water moves out from the cell into the extracellular compartment. So as the water is more here, it will be less viscous. But what happens in the cystic fibrosis is, we have the mutation of this CFTR gene. So when there is a mutation of the CFTR gene, the chloride transporter proteins are not normal. So the chloride cannot be transported out. So chloride stays within the cell, but the sodium channels are normal. So sodium will be moving into the cell. Now as the sodium is moving into the cell, because of the increased concentration, even the water moves into the cell. So water in the extracellular compartment starts reducing, and intracellular compartment it increases. So what happens is, on the surface where we should have the salty water solution, that will get depleted because water is in the cell, and then the cilia will come in direct contact with the viscous mucin. So there will be the collapse of this cilia, and there will be defective mucociliary clearance. So when you have a defective mucociliary clearance, the cilia cannot move. So there will be a thick viscid mucus which gets accumulated. So again, in these accumulated secretions, you have the secondary bacterial growth, inflammatory reaction, and destruction of the wall. That again causes the bronchiectasis. This is the cause for the bronchiectasis in the cystic fibrosis. Now another condition is immotile cilia syndrome or Carter syndrome. So when we see a normal cilia, the cilia which is present on the epithelium, The structure of the cilia, it has the microtubules, and these microtubules are connected by the nexine, and these microtubules have two arms, inner dynein arm and outer dynein arm, and then you have a central radial spoke and a central complex. So in this Carter syndrome, there is the mutations in the genes DNA I1 and DNA H5. Because of the mutations of these genes, there is a loss of this dynein arms, inner dynein and the outer dynein arms. So this is the structure of the cilia in the Carter syndrome. So when you have this loss of the dynein arms, there will be inefficient and unsynchronized ciliary movement. So when you have this, actually the name immotile cilia syndrome is not suitable for it, because there will be the movement of the cilia, but it is inefficient and unsynchronized. So Carter syndrome is more suitable than immotile cilia syndrome. Now, when you have an inefficient motility of the cilia, obviously again you have accumulation of the secretions, and this accumulation of the secretions again becomes a good source for the bacterial growth. Then you have infection and inflammatory destruction of the wall, leading to the bronchiectasis. This is the cause of the bronchiectasis in the Carter syndrome. But you have two other conditions also in the Carter syndrome, that is situs inversus and sinusitis. Actually, it's a triad of these three conditions: situs inversus, sinusitis, and bronchiectasis. Why the situs inversus occurs is when there is a defective ciliary movement, the cell motility during embryogenesis is also defective. So the heart which is developing should go towards the left, and because of abnormality in the motility, it stays back on the right side. And sinusitis is because the lining of the sinus cavities, where you have a ciliated epithelium, that ciliary movement is again defective. So again you have accumulation of secretions causing the infection. So that causes sinusitis. So this is a cause for this triad of situs inversus, sinusitis, and bronchiectasis. Now in the hereditary immune deficiency diseases, there will be defective immune system. So when there is a defective immune system, there will be repeated bacterial infections. So bacterial or the viral infections, and the infections causes inflammation. Inflammation causes again the inflammatory reaction, which causes the destruction and the weakening of the bronchial walls, that causes the irreversible and abnormal dilatation of the bronchi, that causes the bronchiectasis. The another cause is atopic bronchial asthma. This is a very rare cause for the bronchiectasis. In some conditions in the bronchial asthma, there will be a thick viscid mucus secretions, and this thick viscid mucus secretions, they cannot be expelled out. So they stay there, they accumulate, they cause the obstruction, and there will be the accumulation distal to these obstructions. So all this mucinous material, it becomes a good source for the bacterial infection, and then again the same thing, you have inflammatory reaction, and the inflammatory mediators causing the destruction of the bronchial wall, leading to the bronchial dilatation. This is a very rare cause. Actually, the bronchial asthma is rare cause, but these patients can develop bronchiectasis. Now, another one what I told was congenital bronchiectasis. So that congenital bronchiectasis is because of the congenital defects in the development of the bronchial wall. So that finishes about what were the causes for the bronchiectasis. Now, when we see the morphology grossly, bronchiectasis, it usually involves the segmental bronchi, which is it involves a distal bronchi which is beyond the segmental bronchi. Okay, and bilateral, usually if it's an infection, usually the bilateral involvement will be present with the involving the lower lobes. And if the cause is obstruction, then only the single lobe will be involved. And most commonly we see the left lower lobes involvement than when compared to the right side. Now when we see the appearance, this is a normal lung where you have the bronchi, normal bronchi, but here when you see the cut section of the lung which has a bronchiectasis, we have a numerous cystically dilated bronchi. And grossly when you see this cystically dilated bronchi, the appearance resembles the honeycomb. So the term which they use for describing the gross appearance of the lung in the bronchiectasis is honeycomb appearance. Then this is again subclassified depending upon the shape of the dilatations, the gross appearance in the shape. So if it is a spindle shaped dilatation, we call it as a fusiform. If it is a tube like dilatation, we call it as cylindrical type of the bronchiectasis. If it is irregular dilatation, we call it as a varicose. And if we have a sac like dilatation, we call it as a saccular. So this is the subclassification depending upon the shape of the dilatations. Now when we see the cut section of the dilated bronchi, so first thing is the bronchi are dilated. Then when we see the this mucous layer, it has a wrinkled surface. It has a wrinkled and thickened mucosa. You see this surface, it is wrinkled and thickened mucosa, and it will be edematous. So it appears thickened because it is edematous, which is infiltrated with the inflammatory cells. And then the lumen will be showing a very thick mucin in it. And in between this dilated bronchi, the lung parenchyma will be reduced, and slowly it undergoes the fibrosis. So the gross appearance, when you see, you have to describe the term as honeycomb appearance. Then you describe about the inner cut section, how it appears. So you have a thickened mucous layer, the surface which is wrinkled and puckered, and the lumen shows a very thick mucin. Then microscopically, when you see, so if we see from the mucous layer to the outer surface, the mucous layer, there can be the ulceration of the epithelium because of the inflammatory cells and inflammatory destruction. You can have the ulceration, or you can have a squamous metaplasia, that is replacement of the ciliated epithelium by the squamous epithelium, or the epithelium may have non-ciliated columnar epithelium lining, or it can be the normal lining epithelium also. So all these changes you can see in the lining of the mucous layer. Then when we see the underlying subepithelial tissue and the muscularis, we have a diffuse inflammatory cells. You have acute and the chronic inflammatory cells which are infiltrating both the subepithelial layer and also the muscle layer. Now this inflammatory cells, they cause the destruction, so there can be the fibrosis also later as a healing process. Then in between this dilated bronchi, the lung parenchyma will be showing the fibrosis. And even the pleura which is overlying this area shows adhesions, and it shows the fibrous bands between the bronchi and the pleura. So whenever you are describing the microscopy, you should describe it from the inner surface to outer side. So describe the changes in the mucosal lining, then you describe the submucosa, then you describe the muscle layer, how it is. Now coming to the clinical presentation, the patient will have a chronic cough with the foul smelling expectoration. Sometimes he can have the hemoptysis also, and he can develop the recurrent pneumonia. And because the lung parenchyma is reduced, the patient will have a severe dyspnea, and he may have the orthopnea with the episodic fever. So classical presentation is chronic cough with the foul smelling expectoration. And when you see the complications, the foremost complication is the patient may develop the lung abscess. If there is a severe infection, the patient will develop the lung abscess. Later on, because of the severe infection, the patient may develop the sepsis also, and he can develop the metastatic abscesses, including the abscess in the brain. Later on, as a healing process, there can be the pulmonary fibrosis. So this is also one of the complications. And as it's a chronic process, the patient may develop the amyloidosis. And once the parenchyma is getting compressed by the dilated bronchi, it will cause pulmonary hypertension and the back pressure on the heart. So that can lead to the heart failure, what we call it as a cor pulmonale. So these are the complications. Patient can have the lung abscess, metastatic abscess, fibrosis, amyloidosis, and the cor pulmonale. Bronchiectasis. And this entire thing is a summary. You should tell the definition, then you should tell the cause and the pathogenesis, which is mainly obstruction, infection, and the congenital conditions. All are interlinked, and in all these conditions there is inflammatory destruction of the muscular and the elastic tissue of the wall leading to the bronchiectasis. Then you have to describe the morphology. Gross features term is honeycomb lung. Then subclassification as fusiform, cylindrical, varicose, and saccular. Then microscopy you have to describe from the epithelium ulcerated with a squamous metaplasia, and you have a diffuse mixed inflammatory cells in all the wall causing destruction of the muscle tissue and the elastic tissue. Then complications, we have the abscess, lung abscess, fibrosis, metastatic abscess, amyloidosis, and the corpal meal. So in the nutshell, when you're writing about the bronchiectasis, you have to include all these things. So that finishes the. Thank you friends for listening patiently. I have started doing the videos after the long time as I was badly affected by the COVID, but from now onwards, I will be uploading my videos. I'll be waiting for your valuable suggestions also. Thank you.